So how do you present to an attending? It's going to differ between whether this patient that you're presenting was a new admission or if you're just giving an update. But listen, there's a universal understood language amongst us all, and that basically follows a SOAP note. It's the subjective portion first, what the patient tells you, what they're saying, what happened. The objective portion next, often starting with the vitals and your own findings, the assessment and the plan. So if you keep that in your head, you'll always be able to present a patient according to a way we can all follow. So when presenting a new patient, say you had an admission last night or yesterday, and this morning you're going to present the patient to the attending. You're going to start off with the age of the patient. It's a 55-year-old male who has a past medical history, and only give the pertinent past medical history. I don't care that he had a hangnail last week. With a past medical history of hypertension and hyperlipidemia with chest pain. He presented with chest pain, and then give us a story, entertain us. So he's been working just fine at his occupation with no problems up until about a week ago. He says that, during some of the more strenuous portions of his job, he starts to experience a tight chest pain sensation that causes him to feel a little short of breath, and he's got to sit down. He doesn't do anything or take anything to relieve the pain, but just sitting down and resting makes it go away. What makes it worse is if he just continues with the strenuous activity. He mentions that it happens also when he walks at night. Then you want to continue with your story. There's no radiation of pain in the jaw or in the left arm. He does say that he gets a little diaphoretic. He denies any fevers. He denies any cough. You're going through the differential of chest pain right now, right? Which is pulmonary embolism, pneumonia. So you give your story and you hit all those things that you were taught to think about and ask the patient when they presented with chest pain, such as alleviating and aggravating factors, associated symptoms, radiation of the pain, the nature of the pain, how severe is the pain. Give us all of that. Entertain us. Give us a story. What happened? How long? Has it ever happened before? So now we know what this patient looked like to you when you were presented with them, maybe in the ER or in the clinic or wherever it may be. If you're going to do the past medical history and so on and so forth, that's fine. But you want to go ahead and tell us, for example, the past medical history, he's hypertensive. Is he controlled? Is he uncontrolled? What medications is he on? Are there any new medications? Whether or not he's ever had a stress test, or if he has coronary artery disease, if he's ever been cathed, and what year was that, and were there findings, and are there stents? So the past medical history, you see, is robust. There's a lot of stuff we want to know. Don't just tell me he has diabetes. What was his A1C? When was it last checked? What medications is he on for that? If you do that, if you combine the past medical history with the medications later, perhaps you can skip the list of medications. Are there allergies? Give me the social. What's his occupation? Is he married? Is he happy? Does he sleep well? What kind of guy is this? And finally, we're moving on now to the vitals and the physical exam. And you see, it doesn't matter how creative you want to be with presenting me this patient, but I want you to stick to the subjective portion and then the objective portion. His vitals now. Now you're going to tell me everything about his vitals, or if they're unremarkable, let me know that. You don't need to list them. But certainly somebody who's coming in with a concern for PE, I want to know whether he's tachycardic or his oxygenation is subpar. And then on physical exam, you just present it head to toe. And you can do the pertinence, and if you're just starting out, you can do the full exam so you get used to presenting it. After that, give me some labs. It's fine to say that the CBC was within normal limits, but if we are wondering whether this guy has a pneumonia, we're going to want to know that there was no elevation in his white blood cell count. Tell me about his electrolyte status, Give me the good stuff like a D-dimer if you got one or needed to get one, a troponin, of course. The EKG, you're going to want to tell me what that was, the chest x-ray, any other studies, and finally, we're at the assessment and plan. Okay? So we went subjective, what the patient told you, the story, the past medical history, all of that, to the objective. You looked at the vitals, you got the blood pressure, you got the general exam, the heart exam, the lung exam, the abdominal exam. You looked at his extremities. What did you find? What did you see? This is not a time to make assessments. This is only a time to tell me what your observations were. Now, assessment and plan is the time to put it all together and tell me what you think. So this is a 55-year-old male with risk factors, presenting with chest pain, unlikely or likely secondary to an acute myocardial infarction. Gosh, I hope not, because then maybe he had a STEMI and went to the cath lab. But you see, what did you think it was? Tell me that, and then give me a few differentials too sprinkled in. And what are you going to do about it? And when you tell me what you're going to do about it, there's an order to that too. You're going to tell me maybe what you've already done. Patient is on O2 for optimal oxygenation above 92%. Blood pressures Q4. Maybe he's on some medications already after the admission and you want to do that. Now tell me what's pending. He's pending going to the cath lab, or he's pending an echo, or pending a nuclear stress test. And finally, part of your plan should be a kind of anticipation of what we may do next should the above findings not reveal the source of this patient's chest pain, or cough, or dizziness, or syncope, or shortness of breath. What have we done? What is being planned to be done? And what are you thinking about doing? Are you going to consult? Are you going to think about consulting? Are you going to think about doing a chest CT? Or are you going to consider something else? A lot of that word is used often, consider. And eventually you may want to give a disposition. So the patient is to stay on the floor, he's pending a cath, or the patient is to stay on the floor, he's requiring O2. Plan on a trial of walking on the floor to make sure his oxygenation doesn't dip. Anticipate discharge home in 1 to 2 days. So that's how you may want to present an official patient that just was admitted that your attending does not know about. The second day, day 2 of his hospitalization, day 3, you're just going to want to give, again, the subjective portion. Patient is feeling much better. He denies any shortness of breath or chest pain this morning. He tolerated his meals well. Yesterday, he actually went out on a walk. He had some family visitors. Everybody says he looks good. He feels well. He's anticipating going home and wonders when. The nurse had nothing to report overnight. His vitals were this or that. His physical exam today was this. And your assessment is that this is a 55-year-old male admitted for chest pain, likely secondary to unstable angina, tolerating our treatments and so on and so forth. Anticipate discharge home tomorrow. So it's a lot quicker, a lot more succinct, but it follows that formula that we're all familiar with, that universal formula of subjective and then the objective, and finally wrap it up in a bow for me with an assessment and a plan.